The metastatic castration-resistant setting is a unique setting in the sense that we now have 6 life-prolonging agents for these patients. The M0 space is a much more complex patient population because they're healthier. They don't have any evidence of disease in the scans, so there is a concern about how much impact you're going to have in someone's quality of life for the benefit that you're going to have. I think unequivocally the metastasis-free survival data for the 3 existing agents is something that is very hard to ignore. I think my biggest question is going to be, I really want to see the survival data maturing and seeing if you really impacted mortality, from prostate cancer in the patient population. I also believe that the M0 space is something that has been created by us, specifically when you initiate androgen deprivation therapy in men without metastatic disease. That's what we call the biochemical recurrence setting or non-metastatic setting in the castration-naive disease space. So I think that is induced by what we do. And lastly, I do believe that the M0 space is likely to continue shrinking over time just by virtue of new imaging technology. We now have fluciclovine PETs, we have PSMA PETs, and the likelihood of those new emerging imaging technologies to detect even disease that we didn't think one can have before is significant, which means that it's very possible that with new imaging, the M0 patient population will not be M0, rather will be M1 in nature. The use of this class of agents earlier in the natural history of prostate cancer has actually really changed how we practice. It is clear that now we know that the addition of apalutamide, abiraterone acetate, and enzalutamide are part of the standard of care for men with castration naive or castration-sensitive disease, regardless of volume, even high or low volume disease. And there is a trial called ARASENS that will define the triple therapy combination of darolutamide, docetaxel, and ADT against ADT and docetaxel for men with de novo metastatic disease. Perhaps if you think even further, I think the use of this class of agents even in the neoadjuvant or adjuvant space, or when we use AR inhibitors in combination with radiation therapy, whether it is in the adjuvant or salvage space, is something that we're actually looking right now in clinical trials, and I think that they will repave again how we manage our patients even early. Oftentimes the question in prostate cancer is timing of treatment. So the bigger question is the early introduction of these agents. It is very likely that may change the biology of one's disease, but yet the bigger question is it really destined to change natural history and therefore mortality from prostate cancer?